Hello everyone. Today we will be doing dementia, history taking, and how to manage a station if you're asked about differentiating the different types of dementia. For history taking, we are going to use the following or the below structure. First things first, whenever you're entering the station, the first thing you have to do is introduce yourself and obtain consent, confirm patient's name and age, and ask patient if they're okay if we ask about their family member or the person who brought them in or the person who is accompanying them about their condition. This will help us give us an idea. This will give us an idea of what others have noticed versus what the patient notices. In dementia, Alzheimer's, etc., the memory loss is very gradual, and patient themselves may not realize that they are uh, having deficits or impairment in their cognition, but family members can notice it. That's why it's a good idea to have a collateral history from a family member, spouse, preferably children, siblings, etc., whoever is available, or even caretakers who deal with the patient on regular basis. We can involve them in the patient's care since they will be taking care of the patient. Once you enter the station or the patient's room, introduce yourself. For example, hi, my name is Dr. Faz. I'm one of the physicians working in this clinic or working in this setting or this hospital. I'll be talking to about, or I will be your provider for the day, and we will discuss some concerns about your memory. Is it all right with you? Remember, as of now, patient hasn't been diagnosed with dementia. We are just inquiring or taking history of from the patient and or family member to make sure that there is some to make sure that we are not jumping to conclusions. In cases like this, be very careful. Address the patient by their name or preferred name or however they want to be addressed, and do not jump to conclusion that patient has dementia. I can just go ahead and talk to family member. No, talk to patient first. Ask about whether they are comfortable discussing this in front of the family, and if they want us to talk to the family about their concerns. If they give us consent, yes. If we believe during our introduction to the patient that patient is incapable of giving consent, or patient, or we have some concerns about patient current cognitive status or their mental status, and we may feel like we think patient is confused or not fully oriented, in that case we can talk to the family patient. Even though patient may not express explicit consent in those cases, then we can talk to family members because patient is incapacitated or patient is unable to express consent. So in those cases, we may start talking to the family member, but in any case, start with the patient, see how they are. If they're able to answer properly, continue with them. Ask them about whether they're comfortable if we talk to their family member about their health or their memory. Yes, we can then go and talk to the family member, or we can include the family member in the conversation and talk about it. All right. Once you have introduced yourself and gotten consent from the patient, we move on to the concern, or what is concern. So what is the patient's concern or the family's concern? Does the patient feel they have memory issues, or is the family who noticed the patient forgetting things, repeating themselves, asking the same question over and over again, forgetting about faces, getting lost in their own uh, neighborhood? Explore the presenting concern. What changes have you or your family noticed? Patient may say, I think I'm having issues with recalling names, or I'm having issues with remembering events. Okay, we can then go on and follow them up with more questioning. Now, in presenting concern, especially if the concern is about memory or cognitive impairment, ask about whether the changes were noticed suddenly or they happened over a long time. This will help us differentiating dementias and dementia from reversible acute causes such as delirium. Duration is extremely important to ask them how long has it been going on that the patient has issues with recalling things, or ask the patient how long have you felt like your memory is not as good as it was before. They will tell you 2 years, 3 years, 1 year, however long. In dementia, especially if it's Alzheimer's, the course is very slow, so it takes 1 year, 2 years for a patient to actually notice that their memory is getting worse and worse. So they would say, 2 years ago, I started noticing just a little bit of forgetfulness, and then it keeps getting worse, and now it's very bad. Now, next thing is to ask about progression. Is it slowly declining in a straight line, or is it stepwise? Like, patient is normal, they have an event, their cognition comes down, stays there for a while, and then comes down again. That would be stepwise. Stepwise is usually seen in vascular dementias in patients who have strokes or other vascular events. In those cases, they have stepwise. They are at baseline, sudden drop, then stay steady for a while, then another drop. It kind of has a stepwise or kind of stairs-like course: stable, decline, then stable, then decline, kind of like that. However, Alzheimer's, it's more steady decline. It goes like this and keeps going straight down. They keep progressing or getting worse day by day, month by month, year by year. In progression, the important thing is to ask about rapid worsening. Dementia can sometimes get confused with delirium because both can present with similar features. Patient does not recognize people. Patient is acutely confused. That happens in delirium, not in dementia. But in dementia, patients may have baseline confusion. Look for the worsening in those symptoms. And in delirium, one other thing is that it's very acute and very rapid in course. So it wouldn't happen over 6 months. It happens in days or hours. After surgery or after a patient is started on new medicine, anything like that can trigger it. Once we are done with uh, the concern, memory concern, its course, its duration, and its progression, we move on to what have been affected in the patient's cognitive domains. So we have to cover all six of these domains: memory, short term, long term. Short term memory, then we can assess with different questioning. Do you misplace things, or do you remember where things are after you keep them? Yes or no. Long term memory, you can ask them about a past event or a friend from the past, anything like that. Language, in language remember sorry in memory, short-term memory, Alzheimer's usually initially have short-term memory deficits, and then later on long-term, and all those symptoms can get added on. Now, language, word finding difficulty. Does the patient feel like they're unable to speak fluently and have to think about word, and then they can't find a word, and then they have to change their whole sentence? They may have difficulty naming objects. Ask about it. Do you have any difficulty finding words when you're, or do you have any difficulty while speaking? Do you find it difficult to bring up words from your memory? Yes or no. Ask them about, do they have any difficulties naming objects? And do they have any issues with understanding what others are saying? Sometimes that can also give us an idea that they're language wise impaired. Now, once we have covered these two, the next one would be to see their executive function. Executive function, you can ask them about who manages their finances. If they do it themselves, you ask about, are you doing it yourself right now? Yes or no, I couldn't, or haven't been able to follow up with it, or haven't been able to keep up with it. That will give us an idea that they have executive dysfunction. If their finances weren't managed by themselves, or they have an accountant or something, in that case, we ask them about other things. Do you have any difficulty with planning tasks and then going ahead and doing those tasks as planned? Yes or no. We can ask them if they have any difficulty following a recipe or a guidebook. They would say yes or no. This will help us in determining if they have executive dysfunction or not. Next, we move on to visual spatial. Now, getting lost, driving difficulty, recognizing faces or objects. Visual spatial, it refers to how we perceive the environment around us, or how good we can connect the dots or the routes or the maps that we use daily. Um, Patients with dementia sometimes, with dementia, usually they have visuospatial deficits. They get lost in their own neighborhood. For example, they drove to Walmart and then forget how back to get back to home. This is something that can happen in dementia. You can ask them, have you recently noticed that you forgot how to get back to home from somewhere you're familiar with? Or have you noticed any difficulty while driving? Or have you had any difficulty in recognizing things? They will say yes or no. This will give you an idea if they have any visual spatial deficits. Next would be attention and concentration. Um, Patients with dementia, they have poor concentration usually. They get distracted easily and they don't follow on the conversations that are happening. Sometimes you would talk to them for 5 minutes and then they would not know what you were talking about. Now, next thing we have to cover is behavioral changes or personality changes. Now, this is very important. This will help us in differentiating or narrowing down our differential diagnosis to apathy, irritability, disinhibition, paranoia, any of these changes. Disinhibition, we can see it in one specific type of dementia, that is frontotemporal dementia. In this specific type, patients would have disinhibition. They will exhibit um, explicit sexual behaviors, or uh, they may have speech that is inappropriate. They may not have any control over their speech or their behaviors, or they may do inappropriate touching or anything. They can even get charged with sexual assault or other physical assaults, etc. So disinhibition, it is very, if you see disinhibition in patient, think of frontotemporal dementia. Now, fourth thing to check in a patient with dementia is how are they functioning in their daily life? Are they able to do what they used to do? They're bathing, they're dressing, they're toileting. They are they able to feed themselves, or they cannot do that? Are they able to cook for themselves, or they cannot do that? Are they able to shop? Are they able to take their medications on time? Finances, again, it will also come in ADLs, and it comes in executive dysfunction or function too. Driving, same, it comes in visual spatial and also in daily living. Most people have to drive for work or for other reasons. So we can ask about all these, see where they have impairment. Now, normal aging versus dementia. In normal aging, patient may be a little forgetful, but their activity of daily lives are usually not affected. This is a very uh, small difference between normal aging and dementia. So from how do we differentiate dementias from normal aging? Patients in both cases may be a little forgetful, but in dementia, they are functionally impaired. They lose the touch with the activity of daily life that they used to be able to do. It can include dressing, toileting, feeding themselves, cooking, bathing, shopping, going outside, keeping up with friends, etc. It can include a lot of things. So activity of daily lives, make sure you're covering these when you're taking history from patients with dementia. Now, number five or fifth step would be to cover symptoms for reversible causes or other diagnoses. Are they acutely confused? If it is acute confusion, think delirium, not dementia. Dementia is very slow and progressive. Do they have fluctuation in their cognition and hallucinations? If they have cognitive issues, hallucinations, and they have Parkinson's feature, think of Lewy body dementia. Personality changes. Is there any change in their personality? Have they become hypersexual, hyper, or any type of change in their personality? Think of frontotemporal dementia. Stepwise decline. Like I said earlier, steady, sudden decline, then steady, then sudden decline. That's vascular dementia. Ask for head trauma in the past, which can increase the risk of patient uh, in having causes for organic cause of forgetfulness. For example, there could be a chronic bleed. As for deficiency of B12 symptoms, B12 deficiency symptoms like numbness, ask them about getting tired quickly, anemia symptoms, because B12 deficiency causes both anemia and neurological symptoms. Ask them about numbness, tingling, burning sensation in the feet or hands. Ask them about thyroid symptoms. Hypothyroidism can sometimes mimic dementia or memory issues. Ask them about weight gain, cold intolerance, hot intolerance. Ask them about depression or their mood. Be direct with this one. Ask them, how is your mood, or how has your mood been? In elderly, depression may not present with low mood. They usually come seeking help with their memory. And when you follow up with questioning, you can get to depression because the depression was the reason their memory was impaired. Ask about sleep. Sometimes poor sleep in the elderly can make it hard for them to recall details. Ask them about alcohol use, which can increase again their awareness, their concentration, etc. It can impact that. Now, sixth step is to see how safe patient is in their current environment or their home or long-term care, wherever they are. Ask about wandering from patient, not from patient. Usually we do that from caretaker or family member. Has he been wandering around the neighborhood or going to places and then forgetting to come back home or come back to the facility? Yes or no? Ask about falls, patient plus collateral historian, whoever is present. Ask about driving abilities and safety. Are they able to safely drive? Yes or no? If they are not, we have to report them to Ministry of Transportation, who will determine if they're capable of keeping their license or should their license be revoked. Ask them about stoves that they have at home, and if they have ever forgotten the stove, especially the one that uses methane gas, to be on and left, or forgot about it for hours and then came back and someone else or themselves noticed the smell and then turned it off. Ask about errors in taking their medication. And finally, for safety, ask about if they're living alone. If a patient with dementia is living alone, we would provide them with support to help make sure their living environment is safe for them and they have access to services that they may need. uh, in cases that their cognition is impacted badly and they're unable to keep up with their ADLs, those cases we can place them in long-term care or long-term facility or have a home support worker to help them with daily activities. Now, in dementia, make sure you're asking about past medical history, like every other station where we ask about past medical history, but in dementia, we have to include these things in the past medical history. Any history of strokes or TIAs, any features of Parkinson's or history of Parkinson's disease or ever been diagnosed with Parkinson's disease, hypertension, diabetes, depression, head injury. These are the seven things that you have to cover for, six things that you have to cover for a patient who is presenting with memory concerns. This will help us in determining if their dementia or their memory impairment is organic versus inorganic, versus functional or age related. Now, ask about medications that can impact cognition and concentration: anticholinergics, benzodiazepines, opioids, polypharmacy, or patients taking multiple medications at the same time. They are at risk of getting into delirium, or they over time can develop dementia. Now, family history, ask about dementia and family and relatives. Do they have any history of Alzheimer's in the family? History of positive history of Alzheimer's mean they have a higher risk than an average person to have Alzheimer's disease in their life, especially in later life. Social history. In social history, again, living situation, we can cover it here. And at number 6, where we are covering safety, you can cover living situation. But in social history, if you're covering living situation, make sure you ask about uh, adhesive mats in the washroom, good lighting, support rails for the stairs, and support or something to hold on to in the shower so that they don't fall. Ask about if they have any support or any caregiver. Ask about substance use and their education level. Education level is very important. Um, Someone who is not illiterate and someone who has a higher level of education, their MOCA scores are interpreted differently. We will discuss that later on, I guess. So someone who is educated, if they have MOOC of 24, we can say that they have impairment, cognitive impairment. Someone who is non-educated and they come at MOCA score of 24 or 25 or 26, we can say it's not impairment. We will have to follow up that with more testing because we cannot say based on their education level. Now, remember for neck OSCE, these are some scoring points. Uh, Once you are done with the history from dementia or any other station, ask the patient what their perception is or what they think is going on. What do you think is happening? Patient will say, I think I'm developing dementia. They may say, I think I may be depressed. This will help narrow down what's causing patient symptoms. Then ask them about their concerns. What is your most worrisome concern right now? What worries you the most? And finally, ask about expectations. What were you hoping we could do today? Some patients say, I just want to get a medication to help with my moods. I just want a medication to make me remember things. I just want help with, just want someone to help with daily activities. Um, this will help us in determining management plan and the for next steps. Now, once we are done with all this, history taking is complete. In case you go into a station with memory impairment and patient has and the station asks you for differentials, uh, dementia then itself can be any of these. It can be Alzheimer's, vascular dementia, Lewy body, frontotemporal normal pressure hydrocephalus, delirium. It could be also normal aging versus dementia. So make sure you are taking these into consideration. Now, how do we differentiate each of them? First, Alzheimer's. Usually, it's very slow in progression and it's gradual. It doesn't have acute worsening. It stays stable, not stable, but it goes steadily down. Features of Alzheimer's. Initially, short-term memory is impacted. Patient has word finding difficulty. They have visual spatial impairment later on. They usually do not have any focal neurological deficits. Now, in exam or exam clue or for exam, remember patient's normal neurological exam points towards Alzheimer's disease. In imaging, you may see diffuse cortical atrophy, but there may not be any specific findings on imaging or neuroimaging. Buzz line or this one line to remember: gradual decline, gradual memory decline first. This is giving of Alzheimer's disease. Patient's memory decline was gradual and that memory decline preceded everything else. This is pointing towards Alzheimer's disease. Second, dementia or vascular dementia. Usually after stroke, you would see it. In vascular dementia, the progression is stepwise decline. Patient is at baseline, one step decline in sudden decline, then they become steady at that state and may have another sudden decline. So it happens like that and usually is quicker compared to Alzheimer's. Features of vascular dementia: executive dysfunction uh, may be more prominent initially versus memory. You would find focal neurological deficit. They may have facial droop, they may have weakness, they may have any other neurological deficit. And in vascular dementia, gait disturbances are prominent. They have gait disturbances with the executive dysfunction, and usually their mood or emotions are labile. They can start crying, they can get irritable quicker. For exam, remember if there is a patient who had if they give you a history of stroke-like presentation and then they say patient develop hyperreflexia and then they are weak, they have weakness and now memory concerns. So remember, vascular dementia should be top of your diagnostic differentials. Imaging, usually it will show multiple infarcts or the part of brain or white matter that's been affected. They may have plaques or old infarcts, anything. Now, for exam, remember this buzz line. If the decline is sudden and stepwise. This is if decline is stepwise with focal signs. This is vascular dementia. Keep this top of your differential list. Dementia with Lewy bodies. This is dementia plus Parkinsonism. Now, Parkinsonism can also later on develop, patients with Parkinson's can also develop dementia or memory loss. But in Lewy bodies, the dementia precedes the Parkinsonian features. So you may see a patient being described that 3 months ago, 6 months ago, family started noticing that patient has um, memory recall issues or forgetting people's faces or names, and then patient would they will give you a very clear vivid dream like hallucination, like patient sees a very well formed hallucination, like patient sees an orange cat in the house walking around or in eating or something like that. They will give you a very clear hallucination, but partner or family wouldn't see that thing. So usually it's visual hallucination, cognition, impaired cognition, visual hallucination, and then they may add for exam. Usually, if you're doing MCQ even in MCQs, they may add uh, patient coming in had slow walking or bradykinesia, or they had tremor or something like that. They will give you a few features of Parkinsonism. So think of dementia with Lewy bodies. So how it's different from Parkinson's: in dementia with Lewy bodies, cognition and hallucinations occur before features of Parkinsonism. Other clues for Lewy bodies: their REM sleep behavior may be uh, impacted. They may have sensitivity antipsychotics that's higher than other people. They may get more Parkinson features. They may get more dystonias with antipsychotics. Uh, For exam, remember hallucinations plus fluctuating cognition plus Parkinsonism. This is dementia with Lewy bodies. Fourth type of dementia that you would need to differentiate from Alzheimer's or other causes of dementia is frontotemporal. Frontotemporal happens earlier, patients in their 50s or 60s. And the main concern in this type of dementia is usually the disinhibition or the personality change. Patient suddenly becomes apathetic. They don't care about their grandson all of a sudden. They don't care about their family anymore. They started uh, exposing themselves inappropriately to strangers or outside or something like that. This is what usually is the concern. Um, in frontotemporal dementia, patient has dementia plus disinhibition, apathy, loss of empathy, hyperorality or speaking a lot, or they may have aphasia. Um, Memory is usually good initially, it gets worse later on. Now, for exam, remember frontotemporal dementia, behavior or personality changes happen first, memory gets impacted over time. Next is normal pressure hydrocephalus. You can remember this by the mnemonic wobbly, wacky, wet. So they have gait disturbances initially, then get urinary incontinence, and then become uh, cognitively impaired, and then they can develop urinary incontinence. Now, key clue for normal pressure hydrocephalus is it's going to be someone elderly, not too old, but they would have gait issues, then memory concerns, and would finally develop urinary incontinence. When you do imaging, they would have enlarged ventricles. That's the only clue you can find on imaging. Sixth differential that we must rule out before we call someone's dementia Alzheimer's or anything is delirium. Usually it happens within hours to days of some change. It could be patient getting admitted to a hospital, patient getting surgery, a new medication being added to their already multiple medications. And with delirium, the clue is that it's acute confusion and its course fluctuates. They may be normal at one time and then get worse at the other. Usually, their mood gets or their confusion gets worse towards the later part of the day or towards the evening or night, and they may have better cognition during their day or in the early hours of the day. Now, key feature, they don't they have impairedness of their they have impaired attention with the confusion and memory concerns. Now, there are a lot of causes. Remember, infection, medications, metabolic causes. These are some of the common reasons why patients, infections being the most common in the elderly, or medications. They are common causes of delirium in the elderly patient. In most cases, delirium can be reversed quickly. In some cases, it may progress to dementia, but in most cases, it's treatable or reversible. Now, buzzline for delirium is acute and fluctuating, not dementia. It's more likely to be delirium. Here we have a table for differentiating the different types of dementia. For Alzheimer's, onset is gradual. First symptom usually is memory concern or short-term memory. Hallucinations can occur in very late stage. Focal deficits are not present. Parkinsonism is not present. Imaging clue atrophy of cerebral cortex. In muscular dementia, the onset or the progression is stepwise. Their first symptom or initially they have executive dysfunction. Hallucinations are rare in muscular dementia, and they usually have focal deficits. They may not have any Parkinson features. And imaging clue, it may show infarcts. Lewy body, it's also gradual, but hallucinations and cognitive impairment is first, then follows the uh, Parkinsonism. Hallucinations happen early into Lewy body. Focal deficits are not present, and Parkinsonism happens with Lewy body. And imaging clue, you may see mild atrophy or nothing at all. Frontotemporal dementia, it is in younger patient comparatively. They have behavioral issues and memory starts getting impaired later on. They may have hallucinations. Um, they usually do not get any focal deficits or Parkinson's features. When you do imaging, you can see atrophy of frontotemporal lobes. Now, normal pressure hydrocephalus, it's also gradual. Gait is the first to be affected, then memory, and then urine incontinence. They do not usually get hallucination, focal deficits, or Parkinson features. In imaging, you would see large ventricles or enlarged ventricles. Now, investigations that we do for someone who has who is presenting to us with dementia. For all dementia cases, order CBC, electrolytes, creatinine, glucose, A1C, TSH, vitamin B12. Now, the other tests we consider if we think they need it: LFTs, calcium, syphilis, HIV, ASR, CRP. We can consider it if there are any risk factors or if we think they may need it. Imaging, um, we do imaging for dementia. We do CT head in cases of dementia to rule out structural causes. CT head without a contrast, it's first line, and in most scenarios, it can diagnose the cause of dementia if there is any. We look for signs of stroke, uh, usually hemorrhagic stroke, which would be vascular dementia, masses, hematomas, ventricles size. If they are enlarged, then it points towards NPH or normal pressure hydrocephalus. MRI is considered for specific cases. If we are concerned about early onset of the disease, if the presentation is not typical, or if the disease or the dementia is progressing much more rapid than what we expect with the specific diagnosis of the patient. Now, that's all for dementia. We will continue